Well, first of all, I want to really thank the organizer for the kind invitation and more, because this is really a nice environment here. I've never been to CIRM, and it's a great environment, great workshop, great discussion, so really a good job. So, yeah, I will talk about the problem of drug resistance and combination therapies. We have heard several talk on these subjects, and so the idea is that of my research in Politecnico is to try to build mathematical model for complex living systems, so mainly biological systems, but they can be also social systems, social dynamics, for instance, with mathematical frameworks which are mainly those of either structured population dynamics, as we have heard in other talks, for instance, from Tommaso Lorenzi, or also population dynamics. And the general aim is try to understand the pattern of evolution, so the adaptation of the system to the environment, the changing environment. And so trying to build the modeling, the analysis, and numerical simulation with the aim to play with the mathematical model as a virtual laboratory to test some hypotheses, to try to understand a little bit better the interaction between the elements that are playing the game. So more specifically in my talk, I will start with a general setting of the problem of ecology of cancer. So with under the light of the evolutionary dynamics viewpoint. And so then we'll move to the mathematical modeling and the study of the asymptotic behavior, and trying to parameterize the model with experimental data. And then we move to the in silico laboratory, so trying to play with the model, mainly focusing on the problem of monotherapy, combination therapies, so how to design an optimal protocol, so combining different doses, combining different temporal order of administration, so concomitant sequential administration, and so on. And then we will move to a more specific application related to non-small cell lung cancer. Okay, so starting quite general, we already had several nice talks on the problem of evolution. I will be very naive, and the point is that we have the phenotypes, which are the observable characteristic of an organism, and we are interested in the fitness. So the fitness of a phenotype is the ability of this organism to survive and reproduce. So we have really a sort of fitness landscape depending on the type of environment that we are considering. And so focusing on the theory of evolution by means of natural selection, we have that the more adapted organisms are, so the more fitting organisms are the ones that over successive generation reproduce in time, okay? And so these, of course, gives rise to the diversity, so the heterogeneity, the speciation that we see at every level of biological organization. So in this cartoon, you summarize, there is a summarization of the selection process. So if you start from a population with a certain trait, so expressing a certain phenotype, so black bees, and then there is a mutation. Mutation gives rise to diversity, so there is the emergence of a new type of organism with white bees, and then there is the predation. Predation mainly occurs on the black ones, and so there is a competition, and then there is a proliferation of the less predated clones. So basically, we have that with the selection process, we have a remodeling of the population due to the competition, due to, well, mutation and competition. Mutation gives rise to diversity, and competition select the more fitting clones with respect to the specific environment. So when we look at the problem of emergence of resistance in cancer, basically we can focus on a similar process. So we already had several talks explaining us the difference between sensitive cells and resistant cells to treatment. And so in this context, if we have initially a population which is composed mainly by sensitive cells to treatment and few cells which are resistant, when you expose your organism, your sample, to the therapeutical agents, then you will have a selection of the more adapted traits, and in this case the more fitting traits are the ones that are not predated by the therapeutical agents. So you have a remodeling of the population, and you have the emergence of the relapse of resistant cells. So this is something that we want to try to explore, and indeed also from the biological viewpoint there are several experiments that are confirming this type of scenario when you are looking at the problem of relapse under therapies. So in this paper they were looking at the clonal evolution of clones in acute myeloid leukemia after the treatment. So before treatment, you have this situation, so you have the emergence of a dominant clone, of several different dominant clones. So here you have indeed the heterogeneity of the tumor that we have. I had to eliminate my slide because it was the classical slide was already shown 2 times in this workshop, so I say, okay, it's better to eliminate. But you can see heterogeneity even here, because you have several populations that are present in your tumor when it is detected. Then you apply your therapy, your chemotherapy, and there is a shrinkage of the population. So basically, at the first shot, you have a very good response, and the number of tumor cells are reduced. But after, you have the relapse of this brown clone, which at this point wasn't dominant, that after the chemotherapy, so after the environment has changed, it was the dominant one. So in this case, you see, indeed we can neglect mutation because, as pointed out, the resistant clone is already pre-existing before the therapy, and so we really try to look at this problem. So. Also, in the biological literature, indeed, there is the evidence that this evolutionary dynamics is really important, and there are a growing number of papers that are focusing on Darwinian medicine, cancer as an evolutionary process, clonal evolution in cancers, and so on. So the idea is that you have among cancer clone competition for space and resources, and so, for instance, oxygen, glucose, among the cancer cells, but indeed among the cells of a cancer that, as we have heard in previous talks, is made by many different cells. Cancer cells, stroma, you have vessels, you have also immune systems, and so on. And the point is that you have an evolutionary bottleneck, which is due to different selective pressures. So basically, you have the predation of the immune systems, which shape your your population, and also you have your therapies, your drugs, which are changing the environment. So we have really Darwinian microevolution, which select for increased proliferation and survival, and these may lead to the relapse to the therapeutic resistance to invasion and metastasis. So if we want to try to let's say optimize the therapeutic strategies, we should take into account this problem and try to limit the occurrence of the emergence of resistance. And this is something that there are several researchers that are working on. We heard several talk on this problem, and here I just stress the concept of adaptive therapy, so mainly by the group of Bob Gatenby in Moffitt. So they stressed the importance to integrate the principle of evolution in designing mathematical models and experimental methods to develop new strategies to treat cancer. So the point, they outlined the importance to avoid extinction of sensitive clones, and so try to control the number of resistant clones, controlling the total number of cancer rather than trying to eradicate the cancer. So this is a recent contour applied in science. So on the concept of double-blind strategies. So if you have a population of sensitive cells and few resistant cells, then the idea can be adapting for balance. So apply the therapy, so reduce the number of sensitive cells, but in a way some sensitive cells still remain, and they in some way balance the evolution, so that you have, again, after that you stop the therapy, an increase of both cancer clones, and in this way your tumor is still sensible to the therapy. Or the concept of double-blind therapies. So basically, again, starting from a sensitive therapy, you apply a first therapy, then you have the emergence of resistant therapy, then you try to apply a second therapy that's move your system again through the first situation in which you are sensitive clones to the first therapy, and you reapply the first therapy. And so this is also the concept in some biological paper of collateral sensitivity. So trying to exploit this continuous remodeling of your tumoral population driven by the therapeutic agents. And so in this concept, it is really important to tumorigenesis, it takes a village. So we talk about tumor, but indeed we have several different clones, a heterogeneous number of clones, which interact also among them with different types of interactions. So you have competition, you have predation, but you have also mutualism, parasitism, synergy, commensalism, and so on. So it's really from the biological viewpoint, a tough problem, because you have several populations which has different interaction among them. Okay, and so talking about already also this is the problem of giving a talk at the end of the workshop, because several cartoons are already shown. So yesterday Vincent already shown this cartoon. This is the emerging hallmarks of Hannan and Weinberg, and in the new hallmarks that they added in, they stress the importance of avoiding immune destruction. So among several hallmarks, related to the fitness of the phenotype, increasing proliferation, genome instability and mutation, tumor promoting inflammation, they added also the ability of avoiding immune destruction. Because the problem is that the immune system is really a predator of the tumor. And so here it would be an interesting point to look at also the evolutionary dynamics of immune interaction. There is the immunoediting problem, in which you have the shaping of the tumor by the action of the immune system. So, and it's actually a sort of chase and escape dynamics of the tumor, which is trying to avoiding the immune destruction. But anyhow, for our intention, we just want to take into account the immune system as a key player in the dynamics of our problem. And so, in this constant, if we take into account the immune system, of course we have to take into account immunotherapies. Immunotherapies are considered a forefront of cancer treatment. There is again an increasing number of papers that are showing the importance of immunotherapy, but the problem is that not just alone is not sufficient. So is in combination. You need to combine standard therapies to immunotherapies, so that you have that from one side you attack with the classical drugs, and from the other side you sustain the response with of the immune system with the immunotherapies. So we have well, Ursula and Shatter, they did several papers of trying to optimize the problem of optimal protocols, also with respect to the ability of immunotherapies to boost the response of the immune system. And so here we will try to focus on the problem of immunotherapy. So basically they can be either a sort of reinfusion of engineerized CAR T cells that are infused in the patients, or a sort of dendritic cell-based vaccines, so sustaining the memory of the T cells. So, but the idea is try to better comprehend the mechanisms that are underlying the cancer evolution, and try to give some hints to design optimal cancer protocols. So mainly, to be more specific, I will focus on, I will tell you about these what has been published in collaboration with Elena Piretto. She's a PhD student of mine, and Mario Ferraro is Department of Physics at the University of Torino. So on this problem, and again, so the biological question we had in mind were, so which are the evolutionary mechanisms that modify the efficacy of the medical treatments? And so monotherapy or combination therapy, so what to choose, how to take into account the specific tumor that we are considering, and so how to design different therapy doses, different temporal order of administration of the protocol. So, and then we focus on the problem of lung cancer for resistance. So, to keep it simple, as it was also stressed in several papers, we say, okay, we just want to consider two populations, because most of the data are related to just two populations, sensitive clones and resistant clones. So in this way, we use a simple population dynamics approach with two clones. One is sensitive to a specific therapy, and the other one is resistance. Then we have the immune system, and the immune system, we can consider several populations. We just focus on activated T cells that basically have the ability to to kill tumor cells. And of course, also in this context, it's possible in our model it would be possible to take into account different type of effects, because we all know that there is a growing evidence that the immune system has again a twofold role on the cancer cells. From one side, it can really kill cancer cells, but from the other side, it can promote inflammation, so it can help recruiting vessel angiogenesis, and so it can be counterproductive. So, but we just try to focus on the primary effects of the immune system, so the predation. And then we neglect space variables, and we consider an homogeneously mixed system, focusing on two therapies, so a chemotherapy-like therapy and an immunotherapy. So the model is really made of the three populations, so the sensitive clone, the resistant clone, the immune cells, and we have a proliferation of each clone, and then we have the ecology of cancer. So we try to synthesize the main interaction. So we have, for instance, from the side of immune cells, from one side it promotes the clonal expansion of immune cells, so we have a promotion. And from the other side, we have also a killing ability of immune cells on the cancer clones. Again, here, this is a simplification, because we all know that this is not the only direction, because we can, the tumor can have also a immune suppressive ability. So it's not only promotion, but in principle it will be also suppression. But we neglect all say the second order interaction. Okay, and then we have also an interaction among clones. So basically here we don't take into account the whole list of interaction that I showed you before. It's just a sort of competition, which is a direct competition, but indeed this is a competition for resources. So you interact with the other clone, you have a competition because you are seeking for the same resource, for the same oxygens, for the same glucose or whatever. So in this context, we have a standard ODE model, population dynamics model, in which we take into account the two clones, X1, X2, the immune system, proliferation, competition, predation, and we take into account the two therapies. So one chemotherapy, which basically act on the growth rate of the tumor, so increasing the number of dead cells, and a sort of immunotherapy which boosts the ability of the immune system to destroy cancer cells. So of course, we can perform a standard stability analysis looking for the stationary points. We have some unstable points which are no relevance from the biological viewpoint, and one point which is the cancer eradication, which hopefully is something which is occurring very often in our body, because we are creating tumors all the time, which the immune system is able to control and to eradicate. But sometimes there is, unfortunately, the escape of the cancer, and so in this case we have either 2 points of competitive exclusion, so the survival of one cancer clone, the sensitive clone or the resistant clone. Here we are doing an analysis neglecting the therapies, so the competitive exclusion, or a point of coexistence in which you have the coexistence, so the heterogeneity of your systems with sensitive and resistant clone. So of course, we can plot the phase diagram. So here, for instance, you have You have X1, X2, so sensitive clone, resistant clone, and in this case the red one are the unstable points, so no biological reason, and the stable points in this case are the one of competitive exclusion, so either it survived the first clone or the second clone. In this case, the stable point is this one, so without therapies, you will end up with emergence of the dominant clone, which is the sensitive clone. Then you have also the problem of the case of coexistence, in which basically you have that the green one is the stable point, so you have the coexistence of the two cancer clones in time. What is interesting indeed is not really the analysis, the standard analysis, while to try to characterize different types of tumors depending on the parameters. So trying to identify some prototype cancer which are driven by parameters. And so it's possible to compute the stability of the points depending on the parameters. And what I tell you that is mainly driven by the problem of the competitive interaction. So basically, if you have a weak competition among cancer clones, so a weak interaction, you may have coexistence of your cancer clones. If you have a strong competition, then so, for instance, there is one clone with a competitive advantage with respect to the other, then you have the competitive exclusion, so the dominance of one clone or the other. Okay? Okay, and so modeling the therapies, we have, as I told you before, two types of therapy. One is a sort of chemotherapy, like, for instance, this chemotherapy, or a molecular target therapy, which act on decreasing the growth rate of the cancer. And then we take into account the immunotherapy, which increase the efficiency of immune system to kill tumor cells. Okay, of course we can try to evaluate the quantity, the dose that we administered of our therapy. So making the integral over the administration time of your chemotherapy or immunotherapy, you have the total amount that you have administered. Or we can try to find some score that allow us to evaluate the efficacy of one treatment, so basically take into account the reduction of the total cancer load, or the reduction of the resistant clone. And so trying to combine these two indexes, we have a sort of threshold for the effectiveness of a therapy, which tell you information on how good is your therapy in reducing the number of cancer, of the total the total load of cancer, and also to avoid the emergence of the resistant clones. The other point is, of course, we have several parameters. We already had, there was nice discussion by Professor Maney yesterday on this problem. So we can parameterize our model, take into account the data from the literature, and with the same spirit of yesterday, we can try to perform a sensitivity analysis to identify the parameters which are more sensitive. So moving our parameters within the range that we found from the literature, we can try to identify the parameters to which our model is more sensitive, and in this way we can try to refine our parameterization of this on specific data. And so this is exactly what we have done. So for some specific parameters we refer to some data published in the literature on, in this case is colorectal cancer. And so this is the dots and the bar are taken from this paper by Alberto Bardelli, he's in Candiolo, but also Martin Novak and so on, which is published in Nature Communication. And so what you see here is they made an experiment, an in vitro experiment, with trying to evaluate two different types of molecular targets. So the primasertib and cetuximab drug. Okay, so basically the point is that the first clone is sensitive to one drug and the second one is resistant, while the other drug affects both clones. So basically we have here, I report so the dotted line is the sensitive clone, the dashed line is the sensitive clone, the dotted line, you see here the blue one, is the resistant clone, and the yellow line is the total load, so it's the sum of the two populations. Here we have time and the evolution of the density, so we have this is the control case with a sort of exponential growth of our cancer clones. And then here we have the application of the first drug, which affects both clones. And what is more interesting is here. So if you apply our drug, which is able to contrast only the first clone, what you see is that when you have applied the application of the drug, the red dashed, the red dashed, the sensitive clone is reduced. Okay, so probably it's better here because I think that, so here, you have the red one is decreasing, and then there is increasing of the sensitive clone. And then again, you stop your treatment, and when you reapply your treatment, the sensitive clone is reduced, and you have an increase of the blue line, which is the resistant line. So basically, if you plot the total cancer load, which is this yellow line, you have almost this behavior of which is quite good agreement with data. While if you apply a combination therapy, then you are able to follow closely the dots of the experimental data, because basically you are able to control the sensitive clone and also the resistant clone. And then also from this other paper by Ramakrishnan and collaborators, they are still focusing on the problem of colorectal cancer, and they look at the combination of immunotherapy and chemotherapy. And so in this case, we have again on the top the control case in which no drug is applied, and here we have the increase of our two cancer clones, and the total load of cancer is increasing following the dose of experimental data. So then here you have an application of a sort of chemotherapy, and application of immunotherapy, and a combination therapy. Now we try to play with the model. So we try to say, okay, let's see, now that we have found some reasonable range of parameters in which we are moving, let's try to make some in silico laboratory. And so let's see, for instance, in the top left panel, what we see. We are in a situation of coexistence. So basically, we have a weak competition among cancer clones, which you can also think about that there are, you are considering a tumor with enough resources, okay? And so in this case, if we apply a standard chemotherapy, okay, it doesn't work, and so this is inefficient. And this is exactly what we see here. So we have in time the evolution of our cancer clones. So again, the dashed red line is the sensitive clone, the dotted blue line is the resistant clone, and this pink line is the total cancer load. In this bar, you apply your chemotherapy, and what you have is that you have a reduction of the number of sensitive clones after each pulses, and then there is the increase of the resistant clones. So basically, you have the emergence of resistance. Okay, while if you so in this case, the standard chemotherapy is inefficient. If you apply in this center panel a low chemotherapy dose with immunotherapy, what you have is that basically you are able to control the number of sensitive cells without eradicating, and to limit the number of resistant cells, because basically the number of resistant cells is unable to grow because it's controlled not really by your therapy, rather than by the sensitive clone. Okay, so this is exactly the idea of trying to control rather than eradicate. Of course, if you apply a standard chemotherapy with immunotherapy, then you have a reduction of both cancer clones, so of sensitive clone and resistant clone. So basically, there is a sort of trade-off between the decrease of the total load and the control of the resistant clones. Okay? Of course, if we look at this type of therapy, which is a low-dose chemotherapy, is much better from the patient viewpoint because it's less dangerous side effects. But this is another story because we are not really taking into account this aspect. But of course, this is something that say, okay, maybe can be interested to be exploited. While if we are considering a type of cancer which is different, so basically we have strong competition. For instance, there are few resources, so there is a strong competition for resources, and in this case we are in the EC1 case, so we have competitive exclusion in which the sensitive clone is the dominant clone. What we have is that in this case the chemotherapy is really can be effective. So in this left graph, at least you don't have the problem of the emergence of resistance because you can control the number of sensitive clones, and you can also try to consider the other two types of protocols, so the low-dose chemotherapy with immunotherapy and the standard dose chemotherapy with immunotherapy, so leading to a reduction of your cancer. So in this case, the problem of emergence of resistance is less relevant, okay? While if we are in a case of strong competition for resources in which the resistant clone is the dominant one, so the problem is again we have the problem of the emergence of resistance, so is similar to the case of coexistence in which if you apply the standard chemotherapy, you have there is the emergence of the resistant clone. And so here you have this graph, and also you have this graph on the right that tell you the fraction of resistant cells which is increasing after your treatment. Okay, so these bars are your treatment. Okay, and so so this is a message. Say, okay, when we have to take into account to the problem of resistance, well, be careful, take care of the clonal composition of cancer, take care of the kind of interaction that you have, so the competition among clones. Is there an harsh environment so that you have a strong competition, or is there a mild environment in which competition is less relevant, but you may have the problem of the emergence of resistance? So, of course, in this context, there are several interesting applications to trying to go toward an optimal design of treatments and also interruption of the treatment. So you can really try to play with your protocols to limit the number of resistant cells. And in this context, the drug holiday is a therapeutic strategy that really tries to exploit the aspect that drug resistance is a dynamical process. This was already stressed also in the talk by Tommaso Lorenzi. So we have seen that drug resistance is a dynamical process, and here we clearly see in a simple way how it can be dynamical. So the idea of the drug holiday is try to enable the regrowth of the sensitive clones to let your tumor again to be sensitive to your therapy, okay? And besides, also it can be a way to allow patients to recover from the side effects of the therapy. And so in this case, here also there is Jean-Claude Rambaud who has worked on this problem. So I just want to give you some hints. Of course, you can try to apply two protocols, one after the other. And okay, in this case, we are in the case in which the chemotherapy won't work because we are in the competitive exclusion case. So we are in the worst case. But you see that here, if you apply one protocol after the other, then you have the emergence of the sensitive clone. If you wait and make a drug holiday so that you have an interruption, then you have the increasing of the number of the sensitive cells, which allow to naturally control the number of resistant cells, so that here you have a decrease of the number of resistant cells. And so when you reapply your therapy here, again, you have a reduction of the number of sensitive cells, so your tumor is again sensitive to the treatment. While if you apply just after your treatment, basically you will have just side effects and no real benefits. Okay. Okay, so of course I'm running out of time. So of course you can really say, okay, which is the optimal interval? So how long should I wait? So if I apply without no drug holiday, I have this kind of evolution. If I wait a little bit, I have the increase of the sensitive cell. But if you wait too much, okay, your tumor is again sensitive to your treatment, but maybe you have waited too much. So it's a tricky problem. It's really something that you need to tune case by case. Another aspects that so we really try to play with the model to try to understand different cases is the problem of temporal administration. So of course, if you see on the here the problem on this graph is say, okay, let's we have two treatments, immunotherapy and chemotherapy, and so which treatment we do first? So, for instance, in this case, the green, the red bar is immunotherapy first, and the green one is chemotherapy. So, immunotherapy first, we have this scenario. Chemotherapy first, we have this scenario. Okay, so as you see, with the same amount of drug, you have that the final time you have that the chemotherapy first is slightly better than immunotherapy first, because here you have a better reduction of the total cancer load, and also if you see the derivative, so the trend of the tumor, you have that in this case there is a negative trend. Okay, so to do this, we try to also evaluate the fitness, the mean fitness of the cancer population. So trying to take into account well, this sort of logarithmic derivative of our model. And in these heat maps here, we have what we have. So in the above two heat maps, we have the total cancer load. while here we have the average fitness, so the ability to regrow after your therapy. Here on the left is immunotherapy first, on the right chemotherapy first. For instance, if we focus here, we have normalized on this axis, we have the chemotherapy dose, horizontal axis, vertical axis, immunotherapy dose. So if you are, for instance, here, top right corner, what you have is you are in this situation. So you have a good decrease of the cancer load, which is in the checkerboard area, is below the threshold of detectability, which is, well, in this Bardelli paper was 10 to the 6, I think. And also, if you look at the fitness, you have the average fitness of the tumor is low, so you are in this case. While if you apply immunotherapy first, you have well, let's say a good decrease of the total cancer load, but your average fitness is high. So in this way, in this, well, this was in the coexistence case. So in the case of weak competition, it seems that to apply chemotherapy first is the best strategy. So you need to reduce the number of sensitive cells, and then you apply an immunotherapy which sustain the immune response. Okay. So okay, you can play in the different cases, trying to see what's happening in the case of stronger competition. So in the case of strong competition, the result is less clear. So we have cases in which it seems that it's better to apply immunotherapy, and other cases in which it's better to apply chemotherapy. I will skip the details because I'm running out of time, but the point is that really what's the message that I want to tell you is that it's important to take into account the interaction among the cancer clones and the cancer species, even if you want to try to design an optimal therapy. And so if you are in a case of weak competition, so you have coexistence, heterogeneity of your system. For instance, you are in a mild environment in which resources are available, then chemotherapy first approach seems to be the more efficient strategy. While if you are in a case of strong competition, for instance in a harsh environment, then in this case the situation is less clear. So there are cases in which it seems that it's better to do chemotherapy first, cases in which it's better to do immunotherapy first, and this in some way is not so contradictory, because there are experimental findings that suggest that have controversial results, so at least from a mathematician viewpoint. So in some cases, in this paper by the group of group of Moffitt, they suggest a chemo first approach. In other cases, they suggest immuno first approach. So probably the message is that really depends on the type of tumor that you are considering, the type of interaction that you are considering. And so, then of course, after having played with our model, and so with different type of protocols, we have tried to again look at the experimental data. And so in this way we focus on the problem of non-small cell lung cancer, and here is clear from the biological viewpoint that there is a problem of emergence of a second mutation which lead in, I think it's 50% of patients, the resistance to the first drug, treatment drug, so which is the erlotinib. And so in this graph we reported some data from this paper. So this point with the bar are the experimental data, and what you have, they made an in vitro experiment in which they want to test the efficacy of this erlotinib, which is a sort of molecular target therapy, in the case of blue dots, you have your sample which is made just by resistance cells. So of course, even if you put the drug, there is no growth inhibition. In the case of totally sensitive cells, and this is this line, so if you increase the number of, if you increase the dose of your erlotinib, you have a decrease of the growth, so an increase of the growth inhibition, and then this is a mixed sample. Okay, so in this way you see we have at least a good qualitative comparison with experimental data, even if our model was tested in another setting from a parameters viewpoint. And so what was interesting is that they were trying to investigate different type of protocols. So here they on the top left you have they propose these protocols with erlotinib, so which is this tyrosine kinase inhibitor, with pulsed protocols, so this top left graph, with a metronomic schedule, so a sort of low dose concentration schedule, and with a switch to pulse protocol, which is not like your chemo switch in some way, but is just because also here there is just one drug, but you have a sort of bang, and then you have a low dose, a bang and a low dose, and so on. And so in this way, you see that with the pulsed protocol, you have again the emergence, in all cases you have the emergence of the resistance cells. With the metronomic schedule, of course, the total cancer load, which is the yellow line, is not really well controlled in this case, but with a switch to pulse protocol, you can really at least control the number of sensitive cells. So this was the results of the paper, and this is what we have found also with our model. Of course, in this case, we have that there is the emergence of resistance. So then we try to say, okay, what would happen if we applied also a sort of immunotherapy which act on both clones? And so in this case, again, we try to apply it with these protocols they use in the literature, and we have, of course, a better results in controlling the number of resistance cells. So also we can also look at the fraction of resistant cells in the different type of protocols, and what we have is that in the case of switch to pulse protocol, indeed, the fraction of resistant cells is increasing a lot, but also you have the better results from the viewpoint of the total cancer load. While in the metronomic approach, of course, you have a lower increase of the fraction of resistant cells. So basically, the point is that, just to conclude, that is really important to take into account the temporal order, and again, if from one side the maximum tolerated dose, this is a paradigm which is quite clear, is not always the best choice. Another point is that it's really crucial, the composition of your cancer in designing the efficacy of a treatment. And from the application to the lung cancer, the point is that this pulsed protocol has stronger results in terms of total cancer load, in terms of reduction of tumor expansion, but the resistance is accelerated. So if you have a strong selective pressure in terms of your therapeutical drug, then you have also the emergence of resistance. And so in this case, a metronomic low-dose continuous protocol can be combined with a standard pulsed protocol, can be more efficient in reducing the number of cancer load and resistance. And so this is an ongoing project with Dr. Paolo Bironzo in the hospital in Torino, in Orbassano, in which we are really trying to collect some, they are working in, really on the problem of non-small cell lung cancer, and we are discussing, we are trying to collect some data to test this hypothesis, and so trying to be really applied to our application. So just to finish with this nice cartoon again by Robert Gatenby, so trying to integrate the principle of evolution in design and strategy. So it's, sometimes it's better to control rather than eradicate cancer. Okay, so thank you for your attention.